All right. Hello, everyone. Welcome to the Christina Crow podcast, where we are connecting the dots in search of more balanced mental health. Today, we're making the invisible things visible. In today's episode, I have the great privilege of sitting with Dr. Joan Flood. Dr. Flood is a graduate of McGill University and the University of Manitoba. Since 2004, her practice has been focused on ADHD, learning disabilities, and autism. For 7 years, she was the consulting physician to the Pine River Institute, a residential treatment center for teenagers with substance use and concurrent psychiatric disorders. Dr. Flood is a board member of CADDRA, the Canadian ADHD Resource Alliance, an organization that provides physicians across Canada with scientifically supported guidelines for diagnosing and treating ADHD. In CADDRA, Dr. Flood shares her expertise and leadership on several committees. She chairs the Advocacy Committee, a group dedicated to speaking with government officials and advocating for disability tax credit and medication coverage on behalf of individuals with ADHD. She also serves on CADDRA's Education Committee, a group sharing specific standards of practice for ADHD assessment and treatment with Canadian clinicians. She's a strong advocate for individuals with ADHD, believing in their ability to succeed with appropriate medical and psychosocial support. Thank you so much for making time to be with us today.
Oh, thanks, Christina. It's a pleasure to be here with you as well. And you've so kindly read my bio, but I'm going to come right back at you and say you have my great respect for all the work you do in ADHD. And your listeners should know that you too are a member of CADDRA, the Canadian ADHD Resource Alliance, and you are a very active and helpful member of my Advocacy Committee. And you've been able to provide a lot of the non-physician view of ADHD and the needs of ADHD clients, which really round out our experience in terms of helping people with ADHD. So
thank you. That's great. I mean, when I first had the opportunity to join CADDRA, to learn what I could from medical colleagues, knowing that with ADHD, that's a huge component of people really making these transformational, recoveries, movements forward, I guess, as we know that they can, that's the part that's missing. Like, our systems are so splintered, right? So then when the opportunity came to join a committee, I was like, yes, kind of rubbing my hands together. Like, I can get closer to these doctors. Like, I need to be able to get to know these guys to get the benefit of that part of the journey. So it's been really great.
Well, and I'll say one of the things that we are working on in advocacy, and you've certainly shared your input on that, is the tremendous difficulty people have in getting assessments for ADHD across the country.
Yes.
There are simply not enough qualified clinicians who can assess and manage ADHD. And that is something that we are really trying to push. I think our current government is prepared to take a much better look at the mental health of Canadians, particularly with all that's happened with respect to COVID, which has been very stressful on Canadians at large, particularly those with ADHD. And another area of mental health that's really problematic is substance use and various forms of addiction. And people with ADHD are more prone to addictions of many different natures. So we are submitting to government on, our desire that ADHD become much more recognized in Canada as a significant mental health disorder that is very manageable, very treatable, and management of ADHD can really be life-changing. So I think it's really important that we do that. So advocacy is a long game, but I hope that we can keep the game consistent and we can make some forward growth in the experience of those who do have ADHD.
Yeah, it's so nice, I think, for anyone listening to hear that, because the patients listening on the other end who haven't had the benefit of speaking to a medical ADHD specialized doc is like, no one knows what I'm going through. I can't get the right, medical expertise. I don't know what I'm doing with this medication. It feels so lonely out there. And then it's so nice, oftentimes I'll share, you guys wouldn't believe what's going on the back end. You just haven't seen it yet. There's so much advocacy and so much passion. And so I think for you to be able to say that to whoever's listening that can hear that will bring great relief, at least to know that there's people working on it, right?
Mm-hmm. Yeah.
Yeah. How do you think we got to this point where there are, because it's such a, like you think family physicians such as yourself, you see whole families through a lifespan.
Mm-hmm.
Like, how is it exactly that something that affects so many people within a family kind of has gone unrecognized in the general practices out there?
Well, I think the belief has been through, many decades and centuries that we choose our behavior, we choose our personality, that our genetics and our neurobiology have nothing to do with it. So I think, 50 years ago, you probably would have looked at a student and say, oh, good student settles down work, or lazy student doesn't apply themselves. It was never a query as to, well, how come that really good student can sit still and engage with learning and do the exciting parts and do the sort of not so exciting repetitive parts, and this other person just can't engage unless it's something really stimulating, and they're getting sidetracked. And how many adults today dropped out of high school because they couldn't sit and absorb the information? And they probably have said, oh, well, I was just bored. Well, when I pick apart bored, it often means I really couldn't listen. I really couldn't engage. It was just torture for me to have to sit in a classroom and listen to the teacher droning on, kind of like the teacher from Charlie Brown with that.
Right.
Exactly. So
You're right.
I
was gonna say the way the material is presented too. Like I find with my kids in school, their teachers, I mean, at least what I've seen, present material to be learned in so many different ways. Like learning is so much more active and engaged. There's opportunities to get involved and work in groups. I don't remember it being like that when I was a kid. Like we had to sit in our desks and it was very didactic. And if that didn't work for you, like good luck,
Exactly. I can remember one of my sons had a teacher who taught them caveman math, and he would come into class dressed as a caveman. Well, I mean, the kids lapped it up.
Love that. That's great.
And they learned their basic arithmetic from the caveman. Yeah.
In high school, I had an English teacher that dressed up like Darth Vader during one of our English lit. We'd play like the Star Wars theme song as we wrote our exams. Like he was very bringing into other elements. It stands out so much. It was such a great class.
Exactly.
Okay.
So that's the case.
Yeah. And so, speaking about kids in school, and there's definitely different schools and different teachers with different types of training, the ones that really can figure out how different brains learn and engage them, because all these things are kind of invisible, right? Like we don't know if someone's got excuse me, a learning disability, and they just learn differently. It doesn't mean they can't learn. It just means they maybe need to listen to Romeo and Juliet on an audiobook rather than read it. So it's like, who cares really how it gets in, as long as it's in, and then we can output it in different ways as well, what we've learned.
Yeah.
And once kids figure out that, oh, there's another way I can do it and it's okay, to your point, people can make these transformational kind of movements forward, right?
Exactly.
Yeah. So can you share with us a little bit your thoughts about like familial pieces? So I'll tell you, I do these TikTok videos, and every now and then I look back, and so you can do this look back, say, well, which video was your most popular one over the last 3 months or 6 months? And it inevitably is always a video that is about the familial impacts of ADHD. Like you're not the only one, with ADHD in your family, even though nobody else is diagnosed. And you hear the stories that people tell, it's like clearly, we're the it's a strong vibe in the family, right? So what do you see is in your work?
So I can talk about familial and I can talk about family.
Mm,
First of all, it's highly unlikely that you are the only person with ADHD in your family because ADHD is highly familial. It's as familial as height. And we all know that we are generally somewhat of a combination of the heights of our parents and their respective families. So ADHD is highly familial. Other causes of ADHD, such as really serious head trauma, being born prematurely, like 2-3 months prematurely, and those are the minority of people with ADHD. More often than not, it is familial. And there may be an identified person in the family with ADHD, but other family members likely have ADHD or associated disorders, or some of the features of ADHD, they are maybe sub-threshold. And so I think that's one of the things. I have a very large extended family, and many of my family members do have ADHD, many do not. And I certainly can see the impact of that. The person who has quite symptomatic ADHD is often kind of earmarked as sort of the annoying nuisance person in the family, and why can't they remember that dinner is at such a time, or, it's so-and-so's birthday, or you've got to buy a wedding gift for this person, why can't they get it all together? Everybody else can.
right.
So, there's often a lot of, talk about, this person who may be not meeting up to the expectations of family members who maybe have better executive functions.
Mm-hmm.
So, there's often that identification. Within families, ADHD is challenging because the person with ADHD often, is forgetful or doesn't manage their schedule as well, which can be challenging. So if you have, three children that have to get into the car to get to school in the morning, and one of them is still upstairs in their pajamas when the other one has to be at school on time for, a basketball practice, there's lots of yelling and screaming and upset. And, whoever is driving the car with these upsetting children in the back is on edge, even just driving the car. Right. So there's those aspects. A parent with ADHD and a child with ADHD often really come to blows with each other, not necessarily physically, but, emotionally, whatever. I think ADHD parents themselves have, a short attention span and a short fuse in terms of dealing with some of the perhaps inattentive, hyperactive, impulsive, emotionally dysregulated aspects of their family members. So, so it's familial and it affects one's family for certain.
Do you have, so as a clinician, has it changed over the years, or do you have a way of highlighting the things you observe to the undiagnosed family members or parents, especially if it would really benefit the one child? Because often I'll tell you what I'm faced with, even though, so for those of you that are not from Ontario that are listening, as a psychotherapist, I don't diagnose, but I assess, refer for diagnosis, and then do treatment when people come back from a psychosocial perspective. So when I'm working with something, often what I've seen is kind of that scenario I described before. I'll see the younger sibling of someone who was diagnosed. Mm-hmm. So I'm seeing this person as a late teen or in their early 20s. And it turns out they have all the markers of like an inattentive type or a late diagnosed, maybe the way girls and women present with ADHD often. And no one ever looked at them because their older sibling was such a handful, quote unquote, that they didn't get the attention put on them, And so then, of course, it would have been so much greater if we were all diagnosed at once. And I think there's this idea that when one kid is identified in the family, kind of let's just screen everybody. But I don't know in practice if that actually happens, and if physicians maybe feel like they can look at mom and dad. And I know I don't dance around it anymore with people. Like when I'm talking to parents, I'm like, all right, which one of you two are we talking about here? And how does this show up? And I kind of try to make light of it to kind of disarm everybody, because it's like, it's okay, right? It's okay. We just got to figure out how to untie our shoelaces so we can all make the best of what we've got here. And so I just kind of wonder from like your, like a medical perspective, how you handle that.
Well, you know, this is obviously a parent and child visit because generally
Right.
adults
Yeah.
don't come in with their parents in tow.
Right.
But, you know, sometimes it kind of depends upon the level of awareness of the adults in the room. I mean, some parents come in and they're a bit offended that the school has sent them to you because, you know, they don't see the problems with the child. You know, they manage well with the child fits in with the personality and the temperaments of all the family members, and they don't see the difficulties the child has in learning. Now, it's been very interesting during COVID. There are many families who suddenly came to understand what the teachers have been trying to tell them about their children, that they can't sit still, they can't listen, they can't get the work done. And those parents in the past may have been blaming school because it's boring or the teacher's unengaging or, you know, he's sitting beside distracting peers. And now they kind of are beginning to see, wow, my child really does have a problem. And there have been many parents who brought their kids in because of that recognition. If they're not, you know, some parents will say, you know, I was like this as a kid. And some of them will say, well, I was like this as a kid and I turned out all right. And, you know, sometimes I have to pick away at that because their definition of turning out all right might not exactly be what other people would call turning out all right. Like maybe they really aren't living to their potential. And, you know, it's not always something I can say right at the get-go. And I have to tell you, with such a paucity of clinicians around can treat and manage, I don't think it's really within the bandwidth of every doctor you see to say, okay, let's look at all the, you know, other 24 members of your extended family and see who has ADHD. But certainly primary care clinicians, your family doctor, nurse practitioner may recognize that, you know, this person has ADHD and might have a greater index of suspicion in looking at other family members along the way. And there are a number of parents who will bring kids in and say, you know, my son was diagnosed when he's 7 or 8 years of age and he's been treated for several years. And now my daughter, you know, different symptoms, but I notice that she really, you know, struggles to pay attention or she gets really, you know, overwhelmed and upset about things that I don't think she should get so upset about. So they'll often, you know, so there is more awareness, and certainly there's more awareness of ADHD on the part of the public and clinicians over the last decade than have been in the past, but still we have a long ways to go.
Yeah, I know. I mean, you're right? Like it comes down to even the capacity of all of the docs that are out there. Like maybe they don't see the whole family. Maybe they see just a couple members of the family. So they wouldn't go then and be investigating other things. And, you know, we're always really even specific when we try to encourage people to ask for a referral. If their family doctor can diagnose them and treat them, amazing. And we'll work hand in hand with them to support them along the way. And if not, that they really need to look for an adult psychiatrist or a clinician, a child psychiatrist who's like subspecialized in ADHD. Like they have some declared specialty somewhere in ADHD. So we're often referring people to CADDRA and to CADDRA to like look for names, right?
Right. And then when the patients get referred, they discover there aren't that many names. But we really are trying to
improve. We're getting there.
We're trying to improve the education for sure.
Yeah, I know. The stuff that CADDRA has put out has been amazing. They've just launched the new ADHD Learn portal and courses for other physicians who are interested in ADHD. So it's amazing to see those resources.
I do offer, you know, through CADDRA, I have taught many workshops that have educated family doctors, pediatricians, and even psychiatrists about ADHD, because in actual fact, the learning of ADHD in the various medical schools, nursing schools, et cetera, is woefully inadequate given the incidence of ADHD in our population.
Do you think that's changing?
Slowly.
at the med school level, like at the graduate program level?
I would say slowly, but it's got a long ways to go. And we are trying to give them a push to better identify.
Okay, so I just want to turn to, I've got a doc here. So I know the one thing that everybody is going to want to hear about are like pearls and tips about medication management and the role of medication, because I can talk forever about all the other things. So, are there medication kind of best practices that we can share with people, both for people who have had the benefit of psychostimulants and then people who haven't, who've maybe been offered other things?
So it's very interesting because I will sometimes have, I tend to see more children and adolescents, although I do have an adult practice as well. But more typically children and adolescents. And I'll often get parents will bring a kid in and say, well, the teacher or whoever thinks they have ADHD, and I would like to get the diagnosis so they can get accommodation in school, but I don't want them on medication.
Right.
And so, I have to kind of take a deep breath, go through the history taking and whatever, and then explain this to them. ADHD is not chosen behavior. ADHD is a neurobiological disorder. That means that people who have ADHD have differences in their brain than people who do not have differences in their brain. And in a nutshell, the prefrontal cortex, that's the front of your brain behind your eyes, is the part of your brain that takes in everything you hear, see, etc. All the input comes in. It's sort of the revolving door that lets in what's important and extrude what's not, so that you can focus on whatever your task is, whether that's walking safely across the street or writing an English essay or making a decision whether or not you decide to have an affair or do something impulsive. So that executive function part of your brain is deficient in neurotransmission. Okay, big words. So what does that mean? Our nerve cells communicate one to the other by neurochemicals or messengers that pass on the message. And in ADHD, the messengers are predominantly dopamine and norepinephrine. Now, all of us have lots of dopamine and norepinephrine in our system. It's not like, oh, if you eat a bit more broccoli, you'll have more dopamine and you'll be fine. We have lots of dopamine and norepinephrine. The problem is that the neurons in the brain do not release sufficient amounts of dopamine and norepinephrine when it is necessary to pass on the impulse from one nerve to the next. So that part of the brain doesn't work as well. So what does that feel like? Well, I can give an example that everyone knows about. It's like a bad internet connection.
Oh,
you know how frustrating it is. You're all there, you're watching, say, Netflix, your favorite show, and your internet is at 1 bar, not 4 bars. And you get some of it and then it stops and it freezes and then it comes back 2 minutes
buffering
later, something, or you have to turn it off, you have to reboot it, you have to go back to the modem. We know what that's like. Well, that's kind of how an ADHD brain works. All right. So that is a biological problem because of poor neurotransmission. So how do medications work? Well, they are called stimulant medications because they stimulate the neurotransmitters to leave the presynaptic, the synapse is the place in between. They stimulate the presynaptic neuron to release those neurotransmitters into the synaptic space so they can travel across to the next neuron and pass on that information.
It's like a jet stream.
Yeah, so that's exactly how the medications work. And I'll often say to patients, this is not really all that unlike diabetes. I mean, in diabetes, our pancreas has trouble making or releasing insulin, okay? If our pancreas cannot release insulin, then our metabolism is completely askew with all sorts of complications due to that metabolic disorder. In ADHD, if our nerve cells cannot release the neurotransmitters, then our cognitive functions are impaired, our executive functions are impaired. And that too has many complications in terms of comorbid disorders like depression, anxiety, oppositionality, tendency to substance use. And Now, people with ADHD don't look after themselves as well. So they tend to have more lifestyle related disorders that impact their overall health as well.
Yeah.
So that's basically how medications work. So when I have that parent who comes in, well, I don't want my child on medication, I then have to kind of say, well, this is why we give people medication. And if people understand that scientific explanation, then, they're often much more receptive to the notion of medications. I will say that it's very hard to treat ADHD without medications. And I'm going to, say to you too, Christina, I mean, what do you see? I mean, providing supportive psychosocial supports to patients with ADHD is important, but but can you make strong inroads if you don't have that functioning prefrontal cortex?
Yeah, so I 100% agree with you. And it's interesting. I wonder if, like, what complicates the matter on our end is like the neuroplasticity piece. And so what I mean by that is I often say, for example, if you've got diabetes, your pancreas is pooched, it's not doing its job. Where insulin is concerned, we replace the insulin and like off you go. And I said, you can do all you want to try and coach your pancreas to do better and set up external supports to do better. It's not going to work, right? And I say often ADHD to me is almost like it's a medical condition. I don't even know sometimes why it's in mental health, other than the consequences of it not being treated, because they wind up with anxiety and depression, then we end up in mental health. But like at its origin, it's a medical condition, is kind of how I describe it in some ways, right?
Well, I would say in many cases, anxiety, depression, bipolar, schizophrenia are all medical disorders too.
Fair.
I mean,
Agreed.
our brain is a biochemical organ, just like our pancreas and liver.
Right.
It has this incredible ability of enabling us to have thought and reason and action. I mean, it's a miracle of being human is that we have a brain.
We do sort of end up stratifying people, right? So people come, say for example, like a late diagnosed or suspected adult who's iffy about medication. Depending on the goals of what they want to achieve, where they think they're at, their lifestyle, their job, the kinds of supports they have around them, I'm really clear about, here's what you can expect based on everything that we know. This is what it might feel like without medication if they're hesitant from the beginning. And this is what it might feel like, with it. And it's so different from depression and anxiety, where medication is on par in terms of, like an evidence base to be just as efficacious as, psychotherapy. It's not like that with ADHD. So when it comes to effect sizes of different treatments, like I actually work hard to try and make that understandable for people, that the reason we do support medication choice with ADHD is because it's not the same as treating anxiety and depression from that perspective. So you can make some inroads initially. The problem is that they're not sustainable, and you'll kind of slip back. And then if you're working with a therapist that isn't ADHD wise or apprised, you'll end up feeling like it's your fault, is that you'll feel like you failed therapy because they'll label you as resistant, and then they'll start digging for some reason as to why you're resistant. And of course it's trauma and so while of course lots of people with late diagnosed ADHD have developmental trauma, not everybody does. And some people have had trauma and healed it, and now their problem is just the lingering ADHD because they've been in therapy already, right? So I also feel strongly from an informed consent point of view that I do the medication psychoeducation piece, because you have to know what you're saying no to for a truly informed consent. And so I just want to make sure people know what they're saying no to, not because I'm trying to convince them to go on medication, right?
That's right.
There's so much misinformation out there.
And I have spoken to some really well-educated senior people. I'm thinking in particular of one highly respected person who works within the universities and government, not a medical person, who said, "Oh yeah, but that's really controversial. You have to give people drugs." And I said, well, I had to kind of, take her back and explain to her. She said, well, I had no idea, because there is this, there's kind of this stigma about what ADHD is. It's the misbehaving boy who acts out in school, and kind of the menace sort of persona. And you have to give them all sorts of Ritalin, and they're crazy. And that's not the case at all. And in fact, I think that something that we are seeing is that, we have the ability to image the brain today in far greater ways than we did 20 years ago even. Now, I can't send patients for, brain scans, but within big research centers, Harvard is one of the big ones. Sick Kids have done, and KMH have done a fair bit of neuroimaging as well. We can look at individuals with ADHD, and we know that their brain develops much more slowly through childhood. We also know there are volumetric differences in the brain. Certain parts of the brain that are involved in executive functioning are smaller in people who have ADHD. And it has been noted that those who are treated and medicated have a somewhat return of the brain to the trajectory of neurotypical people. So we're looking at children and adolescents who are being treated and medicated for ADHD, and we do see that their brain imaging seems to be much more like the neurotypical patient. Does that mean the medication actually makes the brain grow and develop, or does that mean the medication enables the brain to use those areas? I don't know for sure. I would guess it's the latter. My bicep muscle gets stronger if I do weights and I use it. That part of my brain will develop better. So I think treating ADHD really does help the brain be the best that it can be. And similarly, in adults, there is greater connectivity in parts of the brain in people who are well managed for ADHD than those who are not. So I think that, and we will have much more understanding of this as the years go on. It's a little tricky. You can't go in and biopsy the brain. Obviously, you have to find ways to look inside the brain. And we do have much slicker neuroimaging today than, as I said, 20 years ago. And hopefully that will just continue to increase and enable us to understand much more how our brains work.
That's not really common practice yet, though, is it? To get
no.
Okay.
No. Those are, you have to look at several thousand scans of people with ADHD and people without ADHD to, look at them all together and say, okay, what does the connectivity look like in these 1,000 brains that are medicated compared to these 1,000 that aren't medicated compared to these 1,000 who are not diagnosed with ADHD. So it's not something that one single scan is going to be able to give you information.
Are any of the companies that manufacture and do research in these drugs looking at studies like that?
Well, I can't really comment on that because I'm not really working. I'm not working in that area of ADHD, so I really couldn't answer that.
Okay. Another question that I get often is, there's still not really any patient factors, are there, that determine whether you're going to respond to methylphenidate over amphetamine?
No, there aren't. And that you can pay for somewhat expensive pharmacodynamic testing in the United States that costs several $100s, but in actual fact, the evidence that this testing is valuable is lacking. And I would certainly say that before I'd spend $500 on something like that, I would take that $500 and go have a facial, a massage, and a really nice dinner out with my husband.
That sounds like a good idea.
That kind of money.
Yeah, for sure. Okay. Any other kind of like medication things that come up that you end up having to address often?
Well, people often say, well, can't we, people will often say, well, no, I don't want medication. I want my child or me to see a therapist. I will hear that initially. It is really hard to get, particularly with children, for, if you send them for therapy, the evidence that it is helpful in turning around the executive function deficits is simply not there.
Pretty
Okay.
low. Yeah. Yeah.
Pretty low. And I think you would
Yeah.
say that. Can
I would
therapy
agree.
help support them? Can it help them use their more alert brain, their better functioning brain when they're medicated, in terms of learning how to manage time, learning how to manage their backpack, learning how to behave in a social situation? Yes, like therapy is very helpful, but it needs to work together with medication. And then patients say, well, can I try a non-stimulant medication instead of a stimulant? Because that word stimulant, unfortunately,
there's something stigma about that.
Yeah. So the non-stimulant medications would be medications like Strattera, atomoxetine, or say bupropion, which is Wellbutrin. Those medications kind of work a little bit like putting polysporin on, a festering wound, an abscess that needs hospitalization and intravenous antibiotics.
Right.
They are very much second and third line medications that in typical ADHD have very little impact. Now, sometimes we add them in as adjunctive medication, or to help with anxiety or depression, but standalone medications, they don't tend to work that well. So our CADDRA guidelines are always long-acting stimulants, not short-acting, not Ritalin, not Dexedrine, long-acting stimulants taken once daily and titrated to a dose where there is relief of symptoms. And, sometimes people will get put on like an antidepressant med because
often.
They'll go and say, well, I'm really anxious. I've lost 3 jobs this year. So, okay. So they get a prescription for fluoxetine or citalopram or, something like that. But the anxiety, depression about losing the job isn't the problem. The problem is, why did you lose the job?
That's right.
What was it about you that made you lose the job?
Right.
It's unlikely that something random happened to you on 3 occasions. There's probably something about your behavior. And when you start sort of coming into it, you may get, well, I couldn't be on time. I really struggled. It was very distracting. The work was, repetitive and monotonous, of no interest to me. I started making a lot of mistakes. And so, why is it ADHD is often underneath a lot of the depression and anxiety.
A lot of our work is examining exactly that. What's the context that led you to be in this position in the first place, right? So sometimes it could be obvious things, kind of like some of the things you mentioned, like, timeliness and being, having a lot of conflict at work, those sorts of things. And it could also be a symptom of having no boundaries at work, and a habitual pattern of people walking all over you until you're just burnt out and done. And then the poor performance kind of begins. It signals, the writing on the wall to the way out. And there's really starting to work with people to differentiate. So what I feel like I spend a lot of time doing is helping people identify for themselves, so based on their own lives and their own life experience, what's a symptom and what's them. Because a lot of people think that their symptoms are them. Like that's their personality or that's who they are. And it's like, well, I think if you can treat that and it gets better, that's not your personality. If you can treat that thing and you become much more functional and happier, then that maybe was never your personality, but other people have just been calling it that your whole life because there was no one else really knew what was going on,
Exactly.
And so once people can identify for themselves, like, oh, I'm in this spin again. And, I'm always asking people, how do you connect that crazy story you just told me about last week? How is ADHD involved in that? If it's driving that train, how do you think it is? Because, to your point earlier, it presents really differently in different people. And as soon as people can start making that connection, like, oh, well, I'm not really being flexible in how I'm thinking, or I know I should do that differently, but the day before, I didn't set myself up. Like I didn't plan. I wasn't able to carry through. I got distracted by something else that happened, which resulted in the total, shit show that happened the next day, which resulted in the spiral out,
I think the bottom line, though, in terms of treating ADHD, is that the treatment of ADHD is very successful. And we have something in statistic called number needed to treat. You know, how many people you have to treat to actually, you know, affect a change. And virtually everyone that you treat for ADHD has a benefit from their treatment. It's uncommon that they don't. Whereas if you look at many of the other disorders we treat, such as depression, anxiety, bipolar, schizophrenia, we don't have as much luck at really turning their lives around as we do with ADHD. And the treatment of ADHD can be truly life-changing. And I have had, you know, children run into my office and give me a big hug and say, I got invited to a birthday party, because they've never invited to a birthday party before, because they couldn't behave themselves. And, you know, the message was out among all the families that, oh, don't invite, you know, Sarah or Jackson to your birthday party, you know, or the adult who, you know, sits in your office with tears running down their face and say, I never knew a normal person felt like this. I have gone, you know, back to my job as a high school teacher this year. And normally I'm so tied up in knots and confused. And this year it was all organized. I organized it all. I did it all, you know. So I think that's, I think that's sort of, you know, the reward for me is to see the tremendous impact it makes on people's lives, and to see how it changes their lives when you treat them. And, you know, it's never too late. I mean, we would really like to get children and treat them prior to puberty, before, you know, a lot of impulsive behaviors and comorbid disorders get in the way. But, you know, it's never too late to turn things around. And there are certainly people in their senior years who have been assessed and treated for ADHD as well.
Well, it's funny, you just reminded me in saying that, it's something I kind of thought earlier, was that, you know, when you work with people, you know, with the timing that we get to in therapy, like, I guess in that sense, it's kind of a luxury, right? Like, I get an hour at a time to sit down with somebody and mull through all the parts of their life. Is people don't really realize all the ways they're self-medicating when they're not getting medicated. And when you start to like connect those dots, and it's kind of like, well, you know, I know you don't want to try medication, but these are all the ways you're actually self-medicating without even really knowing that's what you're doing. These behaviors are actually treating the thing that medication would treat. And if you chose the medication route, just something to think about, that's a whole ton of cognitive energy you've just freed up in your life to do something else with, instead of just treading water, right? So we adapt and we come up with all these wily ways to like figure our lives out as we grow up, you know, starting to feel good about ourselves without realizing that, like, it's not supposed to be that hard. You know? And then for, you know, older people too, like there's this whole cohort of like menopausal women who I'm starting to feel like menopause is like being an ADHD 8-year-old boy in some ways, right? Like feeling brain fog and distracted and all over the place and emotional and all those kinds of things. And so it's kind of like there's been some of those neat studies showing the benefit of, you know, stimulants in that population, maybe even if they don't have ADHD, but that could be another life transition where it's revealed.
Well, there certainly is effect of estrogen on the brain. I mean,
Right.
you know, menopause is a hypoestrogenic event.
Yeah.
So women with ADHD may find their ADHD is more problematic as they enter menopause. And similarly, women in the week or so before their menstrual cycle, when their estrogen level drops, they will often have difficulties then as well, you know.
Yeah. What would you, okay, so I kind of, we're kind of coming near the end of our time, but I've kind of like one final question. And it is this piece about self-advocacy, because I think we do have, there has been a surge kind of undeniably of interest in ADHD, of people, you know, hearing about it online, of late diagnosed adults. And it's nice to think, you know, we're closing the gap on all those adults out there that didn't know they had it. And so if they've been on an antidepressant and maybe their family doctor's been treating them for anxiety or depression for however many years, they've tried therapy, it's not working. When they go back to their physician and they try to say, hey, doc, I think I might have ADHD and here's why, and the doctor is not interested in that as a possibility, do you have any like advice for people on how they should approach or talk to a family physician who they know they have a relationship with about seriously exploring this.
Okay. Well, that is that often is very challenging because your family doctor is the gateway to all your other medical care for the most part. And sadly, there has not been sufficient education in the assessment and management of ADHD in the various institutions of, faculties of medicine, nursing schools, et cetera, through the past decades. So a lot of clinicians do not have a good background in ADHD treatment for that reason. And there is sort of this notion that the medications are dangerous and scary. That, one myth is that there are a lot of serious cardiovascular side effects. It is true that stimulant medication can increase one's heart rate and blood pressure. They increase one's heart rate and blood pressure equivalent to a brisk walk up one flight of stairs. Now, there are very few people who can't walk up a flight of stairs in normal day-to-day life. So that cardiovascular risk is highly overemphasized. And the second is the concern that people have that stimulant medications can be drugs of abuse. And it is true that the short-acting medications like Ritalin and Dexedrine can be crushed, snorted, injected, and used as medications of abuse, sort of a poor man's cocaine. But their ability to mimic cocaine is not great. But we do really make an effort to keep short-acting medications off the market for that reason alone. Plus the long-acting medications work so much better and they have so much less chance of a diversion. But here's what we do know is that the treatment of ADHD markedly reduces the incidence of substance use disorder. If you treat a child with long-acting stimulants prior to puberty, their incidence of acquiring a substance use disorder is no greater than that of the general population. Whereas untreated ADHD doubles the prevalence of substance use disorder. So the medications do not lead to substance use disorder. And there have been multiple studies that have shown that's not the case.
They're protective.
So, exactly. So coming back to where you were, so those are a couple of the reasons why doctors are maybe
hesitant,
afraid. And I guess it's a little hard to tell your doctor that they should look up CADDRA and go to one of our workshops because,
we try to do that for them, but
no, and I think that's a really good idea. But, I think if the patient kind of can say, a number of my family members have ADHD and have been successfully treated. I have been looking at the CADDRA or the CADDRA website, which are very reputable Canadian websites. And I'm really recognizing this. And, when I stop and think about all this depression and anxiety I've been struggling with over the last few years, I'm realizing that what's causing the depression and anxiety is my behavior, why am I on my third marriage? Well, I was never that attentive to my spouse. I was drinking too much. I was having affairs, I was doing impulsive things whenever I got frustrated. And, I lost my job for all these various different reasons. And now that I suddenly think about it, maybe it had to do with ADHD or, I started university and I completely flunked out and I couldn't get to class and I couldn't get up on time and I couldn't get things handed in on time. And, I thought I was just a waste of space and I was a disappointment to my parents. And, now that I look at this, I recognize myself in it, so I think that would be it.
Weaving the story together a bit more.
And asking, are there people in your area that have expertise in ADHD that you could be referred to? Over time. And one of the great advantages of the pandemic is we have shifted so much to online medicine, and online assessments of ADHD are very valid.
Yep.
And, over time, I think through the Ontario Telehealth Network, et cetera, more clinicians may be available who can do consultations in ADHD. I mean,
That would
we
be
are
amazing.
very much trying to raise the level of clinicians who can assess ADHD. I know the area I work in, I have a catchment area. I'm not able to take people from all over the province, but, over time, if we can get more people in all the parts of the province who have some experience, or at least know who to go to get help from, because I do
consult
work
with.
with a lot of, I do work and consult with a lot of other physicians
Yeah.
on, how to help them titrate their patients' medications or whatever.
Mhm.
So, hopefully if you have a good relationship with your family doctor, you can move
Mhm.
the needle on that.
You can work it out.
Yeah. Mhm.
Is there information, so I lied, that wasn't my last question. This is my last question. So, but when people come to us, so adults, like before they're on medication and they either already know they have ADHD because they were diagnosed as kids and they're just currently not on medication, or they suspect it. One of the things we do that we wouldn't necessarily offer to another person generally presenting for therapy is we will do more to help them navigate the healthcare system. So we will write, like a consult note that says, this person presented, this has been our assessment, this is the dots we're connecting. Would you, or, do you know someone in your consultative circle with expertise in ADHD that could rule this diagnosis in or out? And we'll send that, we'll give it to the client and they can, or fax it on their behalf to their doctor, because sometimes even doing that is hard with executive function difficulties.
Yes.
And
Yeah.
then occasionally we'll get an interested doc calling back to saying, oh, wow, cool. Like, it's great to get this information. When it comes to, if you know that you've got a patient who's struggling but is seeing a therapist, would you want information back? Because I know when you send someone to a psychiatrist, you get a consult note back. And like, that's a well-established communication process amongst physicians. And I kind of thought it's such a gap in Ontario that between the medical community and the psychotherapy community, that we're not sending these to surround a patient with care, like that care consultation piece.
Yeah.
And
I mean, in a perfect world, right? Sadly, we're all busy in our own areas, and we do practice in silos. I think of my own hospital. I mean, I have at this stage in my career lost touch with a lot of the specialists in other areas of medicine that I would have known when I was a younger physician. I sort of have my own circle of people, and we're not necessarily, connecting with as many out in the community, just because we are all extremely busy and stretched where we are. But I think that communication going back and forth is really helpful. I think too, I found, it's really helpful for me as a physician to have some sense of who the therapist is who has sent a note like that. I mean, I'd certainly look at it, and if it looks like it's well written, it's valid, it's got some, questionnaires that are simple for me to have a quick look at. Like, I really love getting a SNAP questionnaire or an ASRS in exactly the format that it presents on the CADDRA website. It's a very quick way for me to eyeball something without having to spend a long time reading that note. And, I can see that that person probably has a really valid reason to be seen and followed up on. So, I think it is really helpful to have that information. Absolutely.
Okay, that is awesome. Any other takeaways from this conversation that you would like to leave with, our listening audience, which could be a lot of different
so
people.
many takeaways, but here's this.
Yeah.
ADHD is a very real disorder. It's a real neurobiological disorder. It's not chosen behavior or a chosen personality. And ADHD is associated with numerous other comorbid psychiatric disorders like depression, anxiety, learning disabilities, and many, many functional impairments. People with ADHD don't do as well in school, yet they may be very bright. They don't do as well occupationally, yet they may be very capable. They may not be as good in relationships, in friendships, as parents. And so the functional impairments and the, academic intellectual impairments that come along with ADHD certainly create a lot of stress and problems in the lives of those who have ADHD. But here's the line. This is a treatable disorder, and appropriate treatment of ADHD with medications can be life-changing. And you combine that with good, supportive, psychotherapeutic practices like you, in fact, are providing the clients you see, Christina. It can be really helpful because we do have this little comment: pills don't give skills. So, we can bring your brain up to that functioning level, but having that sort of coaching, supportive, how do you manage your life piece combined with that can be make such a difference in the lives of those who we treat. And when you talk to a young person or an adult who has had their ADHD successfully treated, they will tell you it is life-changing.
Well, and it allows people to get all of the hard things under control so that you can get to the strengths. You can realize your potential. I mean, some of the most successful people in the world are people with ADHD.
Oh, without a doubt, because people with ADHD have, they often are tremendous at seeing outside the box. They're often creative. They're often amazing problem solvers. They can often be very intuitive to other people. They can see solutions where other people don't see solutions. I mean, these genes are still in our genome on purpose. And, what's important to understand, medical treatment does not take away or rob that personality.
Right.
It takes away the freneticism.
Yes, that's a good way to put it. I like that.
Yeah.
It really does. Yeah. Thank you so much.
You're welcome. It's been a pleasure talking to you about a
total
topic,
pleasure.
Topic we're both pretty passionate about.
Yeah. And we're so lucky to have a resource like you, like the executive at CADDRA, just the whole organization and everything that all of you are putting together, for ADHD. I mean, it even so, sometimes I say to people, I think, when you find some docs that have like a real passion for ADHD, it might be either because they have it themselves or their family members have it.
Oh yeah.
It's not like some random thing that you pick up and decide you want to subspecialize in, right? And there's a lot of really talented people working really hard who have made good use of these traits. So oftentimes people say, how do you do all the things you do? To me, I'm like, I don't know, sponsored by ADHD. Like, it's just, I don't know how to do anything different. I can't not do all these things, right? That's just part of who I am. So, in all the best ways,
Yeah. Okay, Christina.
Thank you so much.
Oh, and thank you.
Yes.
It was a privilege to be invited on your podcast.
Thank you.
Okay.